Brought to you by
Hello, I am Dr. Henry Dungu. Welcome to your Health Chat here on UBC. I am at the Uganda Cancer Institute, and we are here to demystify issues around cancer chemotherapy. Please walk with me today. Many of you have heard about chemotherapy, and there are lots of misinformation about chemotherapy. And our purpose today is to attempt to demystify issues around chemotherapy. Dr. Clement Okello, welcome to the program.
Thank you, Dr. Dungu, and I'm glad to talk about this chemotherapy. And
what is chemotherapy actually?
Yeah, so chemotherapy is a form of treatment that is used to address or treat cancers, and it can be in the form of tablets or injection medications, essentially just used for treatment of cancers.
People have, they have lots of worries about chemotherapy. How safe is this treatment?
Yeah, actually, when you hear it and when you see patients with cancers, so most people think that chemotherapy is cancer itself. So it's normal if you don't know to be worried about chemotherapy. But all in all, these are really tested drugs that have been proven to help patients, not to make their conditions worse. So I don't think it's unreasonable to worry about it, because, as you know, there can be some side effects that are associated with chemotherapy, but all in all, they are beneficial to the patients.
What are some of the side effects for chemotherapy?
They are varied, just like, and I tell my patients that everything that you take has side effects. Chemotherapy is one of those, including water, actually. If you take a lot of water, you have side effects. Even the common Panadol and all the out-of-counter drugs that we have side effects. But for chemotherapy, definitely they sometimes carry more side effects than other treatments. The commonest that we get, again, first of all, depends on the type of chemotherapy that you have. If you have injection chemotherapies and even these swallowing ones, the commonest side effects you get are the so-called nausea, the sensation of wanting to vomit. Sometimes actually you vomit. And it doesn't apply to all patients. Most patients would actually not get this. And in any case, if they got it, we have ways of getting rid of them. And before most patients get treatment or chemotherapy, we give them some medicine that can actually abrogate these side effects. And even if they get these side effects later, during or after chemotherapy, we still have medicines to give. But all in all, not all patients would get these side effects, and that really is just the beginning of the side effects. Because some of these medicines, we swallow them, those are the commonest ones that could cause nausea, vomiting, and even diarrhea. Some might even cause constipation and feeling of what they say ulcers in the stomach, the gastritis, the burning sensation in the belly. But we also have medications to give to prevent that. The other commonest side effects is just general feeling of fatigue. You are not yourself, so you feel tired. Those are the commonest. There are others that would happen, but these are generally the commonest.
Do you have a mechanism to anticipate this? And are there situations where I would say, no, you are not fit for chemotherapy?
Oh, yeah. So we can anticipate side effects of chemotherapy based on the knowledge that we have of them. For example, we can say, we know this drug A. We know that it's written that the commonest side effects of them are these. So we can tell upfront that patients are likely to get this form of treatment. And again, there are quite a number of them. We can go from A to Z, but generally that is what we can do to anticipate them. So regarding what we can do to prevent, right? So there are many methods we can use. You can prevent it.
Dr. Okello, there are patients who are out there and they want to know, how do I know that after getting chemotherapy I need to go back to the doctor? Are there certain warnings that one should be aware of?
Once you get chemotherapy, the doctor will give you when to come back to see the doctor again. Again, with the anticipation that once you get this chemo today, in so and so number of days, you're likely to get side effects. So the doctor will give you the next appointment as closest as possible, at which time he thinks that you are going to be prone to getting side effects. So the doctor will tell you exactly when to come. And then once you come for the treatment, there are things that the doctor will ask you to do, and what he assesses from you that tells him that you are getting the side effects. He will ask for some lab tests to do. He will examine you to find out. There are some things the doctor will tell you that once you go home, there are things to watch out from. For example, if you're swallowing medicine and you're seeing some rashes in your mouth, some ulcers, the mouth are getting broken, those are the ways to tell that you're getting actual side effects of chemotherapy.
In the event that someone gets that, what do they do?
So if the patient gets that, again, the doctor gives you some medicine to go so that these side effects...
So if they're at home, yes, they have to come back to hospital, is that right?
Not all the time. It depends on the severity. But of course, you have to know that there's an appointment that is always put forward so that you come. But the doctor will tell you, if you get this sensation, it's normal. This is what you have to take to prevent it. But if you get actually severe forms and you're worried that you cannot stay at home, handle this at home, the hospital is open all the time. And sometimes the doctor actually tells you, call me on this number and call the nurse. So the doctor is always prepared to have you back, and all this thing is going to be taken care of.
That makes it clear now. You know, there are patients who worry, in the event I get this, what will happen? But I think you've made it clear. Dr. Okello, what message do you have for those who are out there and are saying, you know what, chemotherapy is terrible, don't dare get near that?
The message I have for them is fear you not so much, because chemotherapy actually helps the patients. It's better to treat the cancer than to leave it not treated. The side effects are there for everything. It's like taking the risk, but you know that the outcome of that risk is bigger than whatever tumbles you'll get along the way. It's manageable. Many patients have come out of it, and I think I encourage the patients to pursue and walk hand in hand with the doctor and follow the guidelines of the doctors. Sometimes people have these myths and they go and hear things outside there which are actually unfounded and leave away what the doctors tell them, and they think that outside information is the actual truth. But my word is, walk with the doctor and follow what the doctor says.
Thank you very much, Dr. Okello, for this. Dr. Okello is a hematologist and oncologist at the Uganda Cancer Institute. By this, it means he's a specialist in blood and blood-related disorders. Thank you very much for being part of the program.
Thank you so much. And Dr. Dungo is my mentor in this.
Tell us about your story. How long have you been attending the Cancer Institute?
I was diagnosed to be having multiple myeloma in 2009. 2009.
Mm-hmm.
And then, I started treatment from that time up to now.
What kind of treatment are you getting?
Well, they have given me various medication, but it has been mainly chemotherapy.
Mainly chemotherapy. With chemotherapy.
Well, sometimes some drugs have caused some side effects, but I think that's bearable if you only understand what you want. The end result is getting treated and cured.
Okay. There are some people who have misconceptions about that.
Well, I don't.
When you talk about chemotherapy or its trouble, what do you think?
Well, I don't know where they get their misgivings from, but at the end of the day, what do they come here for if they are not accepting chemotherapy?
And you said you've had treatment for over 10 years?
Yes, please.
And you're still moving on?
Yes, please.
So which means it has done you very well?
Very, very well.
Okay.
Today I was talking with the director in the morning. He just came, found me out, and he considers it to be a miracle. I don't know whether it's really a miracle that I've been able to survive since then.
Is that what he said?
That's what he said.
Oh, that's interesting.
That's what he said. But perhaps I believe him too.
I think so, because I think you're one of our patients that we've always... You know, there's been a lot of advances in cancer treatment, and what we used to think is impossible is actually now possible, and I think you're an example for that.
That's very encouraging.
Did you ever have a change in your treatment?
No.
Like from one kind of treatment to another line of treatment?
Well, apart from the change in drugs.
They changed the drugs or something?
Yeah.
I think that
Because at some stage I was on thalidomide, pamidronate, then I came to botasamine lately. Although now somehow in between I picked VVD, I don't know where it came from.
You got a blood clot?
Yes, please. But that is being attended to also very well.
Thank you.
Yeah, it's clearing.
Thank you.
I have no complaints.
So this is Mr. Igule, who has been with cancer for about
10 years.
10 years. And he has had chemotherapy before. It has been changed and switched to newer modalities of treatment, and he's still doing well.
Yeah, I still intend to keep on working.
I was diagnosed with the cancer of the right breast, and that was early this year, in around March of this year. I was in the peripheries of the country, that is in Mbale, working until I saw there was some lump in my breast. So I talked to my colleagues and they like, let's go on for checkups. They removed a sample of the meat from the breast. The results came after 2 weeks, and then the results were like poorly differentiated ductal carcinoma of the right breast. Yeah, I kind of broke down, but then with social support, more so family support, we pushed on, and then the doctor referred us to one of the senior doctors in Mulago. That is Dr. Jane Fowler. So she met me. She's been following me up because we settled and did a treatment plan after she did examine me and in comparison with the lab findings. So she advised I should have chemo cycles of about 3 to 4. Then I should be re-examined for probable surgery. So that
she said you first get chemotherapy? Yeah,
for like 3 to 4 cycles, then probable surgery. So that all happened. I had 4 cycles of chemotherapy, and then I had operation this year around July 12th. So then after that, I also went for the 2 cycles of chemo. Yeah, my experience with chemo was not an easy one, because when we had a treatment plan, I broke down because I knew some of the side effects. I have always seen somebody in chemo is like you're driving more to the grave. So I was just wondering how I would catch up with the chemo. But I thank God. I think besides all, God is...
What kind of side effects did you experience?
So many. One, I became a little dry. My skin was very dry. I had alopecia, my hair shed off.
And you lost hair?
I lost my hair. I had long dreads, but it all shaved off. And then I had darkening of the skin. I had nail pains, like the nails could become dark and pain like they want to get off. My CBCs could always drop down the counts. So whenever the CBC was down, like less than 3, I would get the pains, general body pains, especially the bone pains, like I could even just cry. But then,
what kind of support did you get from the Cancer Institute when you were getting into these challenges?
More of counseling, because they advised that before I started the drugs, they took us through the process that we expect some of these side effects, but how to mitigate it. You have to drink a lot. You have to make sure whether you have appetite or you don't have. You need to really force yourself to eat and have a lot of drinks, like water. Always water should be part of your diet. So, and when I started on that, because I also had a lot of vomiting, so they really encouraged me that with that you have to drink and eat a lot of fruits, and I think I followed it up, and I really didn't break down so much. I was able to be going to work, and up to date, even yesterday I worked fast.
There are patients out there with cancer who fear a lot about chemotherapy. What advice would you give them?
Yeah, it's not only them, even me I was fearing, but I think the best thing is we need to empower them with knowledge. They just need to, we need those who know, or the ones who have gone through, should be able to talk, like send out the information and really give the realities about the treatment and the good part of it, that maybe the side effects have to be there, but at the end of the day, you're achieving what you're really looking for. So I think we need to give them information and encourage them.
You said you had lost your hair.
Yeah,
How it has come back.
I lost my hair, and up to date I still have a little stigma at my workplace, because when I'm at workplace I put on a wig. But then my husband has always supported me, and he was the first time he saw the hair, my kids, they're like, "Mommy, your hair has grown." And my husband was like, "Your hair has grown, so you go to the salon," and like they changed the style. So this is like 2 days ago when I went, and I've removed the...
You don't have to wear a wig because it has come back.
Yeah, he actually encouraged me and said, "No, your hair is looking good. It's better than the way it used to be." So, yeah. And
this gives us a message that actually, even when you get side effects of chemotherapy, eventually they go away. Like she had lost her hair has come back.
Even the
skin has come back to normal.
Dark, and the skin is now to my normal color, I would say. The nails, though, I still paint them up, but at least it is clearing. So I don't know, when I've just started this, maybe I'll go back to the, I don't know.
We'll see. Thank you very much. What is your role here?
Our role is to give nursing care, and especially in the infusion room where we administer chemotherapy.
Chemotherapy, people have heard about it, and people are scared about giving chemotherapy.
Yes.
You as a nurse who gives chemotherapy, how is this done?
Chemotherapy is prescribed first by the oncologists that have actually looked at the patient, seen him or her suitable to receive chemotherapy with all the prescribed doses. Then when they come in here to the infusion room, we also go through their blood workups to see where they are fit again, that using the CBC or the blood tests. And once they are fit, we prepare them psychologically through counseling, and also through the good welcome we give them. Yeah.
You mentioned something, ascertaining that they are fit for treatment.
Yes.
Which means there are those that you may not give treatment because they are not safe.
Yes, it is very true.
Many people worry about the side effects of chemotherapy. How do you prevent those?
We do have a number of measures we do to prevent the side effects, much as they do happen, but we try to prevent them. We do give pre-medications, especially in stopping or preventing vomiting. We do rehydrate them. We give them a lot of fluids and also encourage them to take more oral fluids when they are home. Yes.
Do patients tolerate the chemotherapy fairly well, according to your experience?
Many of our patients have tolerated chemotherapy and have come back for their subsequent doses.
Okay.
Yes.
And when they get the treatment, do they experience, for example, response, improvement?
Yeah, for the number of years I've been here, I've seen patients who have survived, those who have even stopped coming, and they just come to greet us, meaning the chemotherapy has responded to them and they are well.
What would be your message for people out there who are scared about use of chemotherapy?
The message is actually to the earlier the better. They should come quickly to UCI and we do our service. We do give them our services. That is the chemotherapy, which really treats the cancer. It's one of the modalities we are using at Cancer Institute to treat our cancers. So chemotherapy is safe.
Chemotherapy, you say it's safe. But is it also safe to you, the person administering it?
We use protective gears to protect us from those other long-term side effects that would occur to us.
So you are also safe?
We are safe in administering it.
Well, thank you very much. I see a lot of activity happening here. What's going on?
This is what we call chemotherapy reconstitution, drug reconstitution. Now what you see here, these bottles are patients' bottles. So we put our drugs in this bottle. This is, for example, D5. There's a drug which is compatible in D5. So dextrose.
Oh, that is sugar water?
Yes, sugar water. So we don't put in any other drug. We have to know that chart. Have you seen that chart? It shows you the stability of different drugs. There's a drug you cannot put in normal saline, but you have to have dextrose. So, for example, this drug is carboplatin. We put it in the bottle of dextrose. It's stable here.
Why do you have to do that?
Here, basically, we have these infusion bottles, the one we put in. We store our drugs here. We shall not give you a vial of, for example, methotrexate, and you go and infuse. We have to dilute it.
Why do we have to reconstitute it?
Now, some drugs come when they are concentrated, and we have to dilute it. For example, this is methotrexate. We diluted it. It comes when it's a powder. This is what they call methotrexate. It's in a powder. The reason why we are here is to reconstitute this drug. It comes in a powder and it's so concentrated, and you have to dilute it. So the diluted drug of methotrexate is this one. As my colleague here is mixing, he diluted this one already. So this is already, you just...
This one is ready to be given to the patient?
Yeah, it's very ready to be given to the patient. We have to put it in the bottle and we know the dose. A patient can, now this one is 1 gram, but a patient can come when he's getting a dose of 30 milligram. So my friend here calculates the dose and then he puts it in the bottle, infusion bottle. Now this is already mixed drug. This drug is already mixed.
Show me that one.
You show him.
How come it's red? Is it for replacing blood or?
No, this is a anti-cancer drug called doxorubicin. I can't show you the name this side, so I'm just showing you the color is red. So this is doxorubicin, and the idea when you see it's vial, it comes like this. It's already red. That's how the manufacturer made it in red color. And when we mix it, this was a bottle of normal saline, it was colorless. But after reconstituting and calculating the exact dose, when you're mixing here, you must have a calculator. Because the doctor will write a dose of 90 milligram. But a vial, for example, will have 1 gram or 1,000 milligram. So my friend here mixes with the calculator. You have to be know the exact amount. You must be accurate. Some drugs here are lethal doses. You know what they call it with the lethal doses?
No.
Or lethal drugs? When you do a mistake here and you give an overdose.
So you have to be extremely accurate.
Accurate. Okay. If it's 20 milligram, you must put 20 milligram. That's the reason why we have the calculator. When you're not sure and you can't use your head, get a calculator, look at the vial, look at the dilution factor, then put in the exact dose.
How come you are working under this?
Yes. You know, safety comes first in our medical profession. You have to protect yourself. Are you seeing how I'm putting on? You have to put on a headgear. You have to put on glasses the way he has put on the glasses. For me, I'm not putting on the glass, but you have to put on a mask. This is the N95. So when I'm here, this place when you're working, you must have an air conditioner. Are you seeing that air conditioner?
I've seen it, yeah.
It must be behind you, and for me I must have this protective. This is a N95, a mask, so that when the fumes come out of this chamber, it takes it like it doesn't affect me. Okay. Now these drugs they fume. Let me show you an example. The reason why we use this biosafety cabinets. One, the drugs must be sterile. The drugs must be safe. For, you know, when I do it from this surface, dust can come in, and any other contamination can come in. So I have to put on, first of all, gloves. We put on 2 gloves. I can make a mistake and I pierce myself, or I can make a mistake and this chemo spores on my hands. So we have to protect our hands with the 2 gloves. My friend is putting on 2 gloves. And then you must have this. The use of this gear is when I'm mixing here, the splash comes.
You are protected.
I'm protected myself.
Now, after you have reconstituted,
yes,
you do this. Would you say now the medicine is safe for the patient?
Yes, the medicine is safe. Actually, after mixing, we put it inside after reconstitution. So he's isolating them from the already mixed drug and non-mixed. This side, they are not mixed. So the use of this chamber, are you seeing this chemo?
Yes, we've seen that.
It's protecting him. So while he was mixing, the splash came. And after coming, it stopped on this mirror. This is chemo. So, and the use of this chamber is a bisect. It has ultraviolet light. I can put on ultraviolet light when I'm done to sterilize the machine. Or actually we have UV light inside, and then down here, you see here, when I put the paper, it goes down.
Oh, because
you see that? Yeah, it sucks the fumes down. So whatever comes out of this biosafety cabinet is safe.
Like, you have all the safety measures to ensure that chemotherapy is given safely. It's not only safe to the patient, but also to you.
To me who is mixing it. That's why, again, when I do this, it takes down. Sucks. The pressure here which is taking away the fumes. So, and when you're mixing it, you make sure that every syringe mixes a particular drug.
You don't reduce syringes.
We don't reduce. And after mixing, we close. You have to close this.
Show me what you have closed.
Now, after removing and you're mixing, you have to take the syringe back to avoid the contamination. Because when you just open it, you use 5FU for doxorubicin and it's affecting the patient.
How come there are 2 chambers?
Yeah, there are 2 chambers. We are supposed to be 2. Now me, I'm demonstrating. That's why I'm not mixing.
So another person will be working for him?
Another person sits here. Another one is here. Another one is inside. Ideally, we are not supposed to come here. That's why we have this. The bottles, when they come in, we don't pass through that door. They give us from here. And someone who is supposed to come here must be sterile.
Since I'm not supposed to be here, let me walk out because I might be in trouble. So we've seen what is in the chambers, and I'm seeing a big refrigerator here. Okay. What is in here?
Now, this fridge, our chemotherapy drugs, there are those they call cold chain, and then those which can be in room temperature. Now there are those drugs, when you put them in the fridge, you're keeping them safe. And even this chemotherapy which is reconstituted, you store them, it has stability. There are drugs which stay for 8 hours, those which stay for 24 hours, but you must have a fridge. Some are stored in the fridge.
Is this like a normal fridge? Or
it's not really a normal fridge, because for it, let me give you an open example. There's a drug called the cyclophosphamide. Actually, here we order in a daily basis. You can't order drugs from the store. Now you're saying that some are not there because we have used them. We don't order once. Because in a day we can work on more than, we can reconstitute around 200 to 300 bottles. Are you seeing these bottles? Now since morning we have reconstituted around 210. We reconstitute a lot of bottles in a day. So the drugs we shall order, they fill this fridge and then they go to done by the end of the day. So a drug like a cyclophosphamide must be in the fridge. It's a cold chain drug. When you put it in room temperature, tomorrow you come back when it's unstable and you can't give it to a patient.
So that's the reason you have
A fridge.
keep refrigerated.
Some drugs which are cold chain, and the bottles the patient they can tell us the patient has.
How do you ensure that this fridge is always on?
What we do, we have the charts. We have the temperature charts. We come every day and we read there, and we ensure that it's in normal condition. We have a chart. We keep on removing them. There's a key here. We open and we remove that chart.
So the circle should be uniform.
Should be uniform. Every day morning before we start mixing the chemo here, we start on the fridge to check. And we open the chambers. We first put on ultraviolet light. So I mean UV light, so that sterilization takes place for 15 minutes. And then the fridge, you have to check the readings, whether they are in normal condition. Then we have to order the drugs for the day. Now we order that in the morning for the drugs. They brought us, so that's why it's getting done. Yeah, that's the fridge.
Thank you very much.
Welcome.
So we have to ensure that temperature is maintained.
Yeah, so what we do here, these are called the constitution papers. So my colleague at the pharmacy writes down the name of a patient. The patient will come, patient's name, the ward. Here we have STC, that is solid tumor center. We have LTC, the former treatment center. We have pediatric ward. We have private wing. There are those from private. We have outpatients. Okay. So all of them we control them within the pharmacy. When a patient comes, you must know the name of the patient. You must know where the patient is going to get chemotherapy from. Is the patient an outpatient? Is he a private patient? Is he an anesthesia patient? We write here.
Okay.
So we write the dose and the drug. Then we start consulting. We have this. We have moved it to this now. When the bottle comes like this, from the pharmacy, someone will record the name, for example, here on the reconstitution sheet. So the name will send the name to this computer. You see here, there's my password here. I'll open it. Then I check what has been sent to me. So this one scans the name of a patient. That's what we are going to now. So I'll just come here, then I press here. The name comes, it prints. That's why we are bringing in a printer and this to just come automatically the name of a patient here. Then we give him the bottle, other than writing the way you have seen here. This is my handwriting. But now we are moving.
So you are getting more
computerized. Yes, we are going more digital. You call it digital?
Digital.
Yes.
Thank you very much for that. Okay.
We are in the cold chain for cancer drugs. In the cold chain here, we store our drugs that require refrigeration. The reason why we opted for a very big cold chain like this, because if you are using several refrigerators, the cost of power and monitoring is very high. But if we put them together like this, it's actually a bit cheaper. Not all our drugs require refrigeration, but quite a number of them require refrigeration, just as you see, many of them. And this is a quite highly monitored area. We have regulation. The monitoring is done even on our phones. Once the temperature is a little bit shoots above the range that we have set it, we are informed. The key people are informed: the pharmacist, the clinical head, and
who informs you?
We have a system that actually sends a message to us, informing us that there is an excursion. So once there is an excursion, we run quickly to monitor what has happened. Is it the power that has gone off? But we have a standby generator, which is visually turns on within 5 minutes to ensure that the drugs are maintained at the required temperatures.
Why do we have to ensure that temperatures are adhered to?
Because these drugs are quite sensitive. Most of them, especially the biologics, these monoclonals, they are very sensitive to temperature. That even having a temperature excursion for quite a small period, you lose their efficacy. And so they will not be working so well for the patient. And that's why we are very keen on monitoring the temperature for these drugs.
We are seeing lots of medicines in here, and I think these are only for the cold chain.
Yes.
And there's been an outcry out there that there are no medicines. What do you have to say about that?
I think for the last 1 year or so, our availability has improved. At the moment, we are at about 90% availability. That does not mean that you're not going to buy anything, but the 10%, you could be a victim that what your drugs are treating you are in the 10%. But majority of our patients now are getting all their drugs for free. We are hoping that as we lobby for some more funding, we shall be able to hit 100%.
Are there challenges that you face in terms of ensuring that people can access these medicines?
Yeah, there are challenges. The cancer drugs are quite very expensive, and it's not only we in Uganda who are finding the challenge. Actually, even the rest of the world, getting access to the cancer drugs is actually a very big challenge. When you go to our neighbors here, the same challenges we face are the same challenges they face. One is because the quantities that we need do not attract the multinationals. So now we are also trying to work together as the East Africans, so that we make our orders together so that we can actually a little bit lower our prices down, and also encouraging more multinationals to come on board. So what I can say is that we as the Cancer Institute, what we have realized is to discuss with the manufacturers and schedule according to their manufacturing schedules, so that we are able to meet the economies of scale as well as get good quality drugs.
Okay. You want to say something about safety, Mr. Sin?
Yeah, I think one of the reasons why people ask why are we moving away from our local traders about anti-cancers, you should be aware that whereas the cancer drugs are used to treat cancer, they can also cause cancer. And so since we are in charge of prevention of cancer and treating cancer, we do not want so many people to get involved in the process of procuring this drug. And that's why what we do is that once the drug is manufactured for us, we want it from the manufacturer to the institute, so that we are actually monitoring this drug. And that's the reason why we have been lobbying that these are highly specialized drugs, and actually they are very dangerous drugs, and so they should not go into several hands, because they can cause many other effects other than cancer. They can cause infertility, they can cause all those dangers. So we want to protect our community and environment, avoid getting in touch with these drugs.
When you say to avoid that, does that mean people should not be treated because they are not safe?
Yeah, when the drugs are in our hands, actually we regulate them in a way that once you're getting the treatment, you're getting in the doses that are required. But also once the patient is getting the treatment, the caretakers are trained on how to handle the waste and the sweat and all that is coming from the patient, because we do not want them to be exposed. And that's why we say that once a patient has got cancer, please, treatment should be done in the cancer center, not in any other clinic. Yeah, because only the UCI, all the cancer centers that have been set up, know how to handle these drugs.
So not everyone can treat cancer?
That is very true.
Not every hospital can handle such...
That is very true. There are conditions that we meet. I think when you saw down there in the pharmacy, how we prepare our drugs is not the way others prepare the other drugs. Because even us, we have to protect ourselves. You saw the gadgets that we put on. We have to protect ourselves because these drugs can actually harm us. And so not everyone should say they can treat the cancer.
Mr. Sinde, there's a fear, as I said earlier. People, they think a lot of negativity about cancer medicines. What message do you have for them, for patients who have cancer?
For those who have cancer, actually the medicines, we have seen good results. I think Dr. Dung will tell you that there are some cancers that are very curable. And if you're treated very well according to the schedules and you're given the right medicines, you will actually get cured of that cancer. So you should actually come and get your treatment, because if you have a curable cancer, you'll get cured. If you have a cancer that it's difficult to cure, still your life will be better when you're getting the treatment.
And Mr. Sinde, again, you spoke about some of these modern medicines that you called biologicals. The other name was monoclonal. Do we access such medicines at the Cancer Institute?
To some extent, we have some drugs like rituximab. We are having access, and those patients, everyone is getting them free of charge. Whereas they are very expensive, our goal is to lobby. We are now working with the Parker Institute of Immunotherapy to ensure that all our immunotherapies can get lower, so that we can access these drugs for every patient. So we are working with very many other people other than government to ensure that we can access these drugs to the patients. Now, the difference between the two, what's the difference between the other ones and the biologicals and the conventional? Now, the biologicals, they just target the cancer where it is. That's why sometimes we call them targeted therapies. Now, what they do is that they make they control the tumor from spreading. And then they have to work together with the other conventional, because the conventional, what it does, it comes and kills these that have been stopped from spreading. So we get the combination of the two, and we get better results, because now it's not spreading anyhowly, and it is controlled. You can now kill it, rather than when you're killing as it is continuing to spread.
You said these are very expensive modern medicines. How much do patients pay for them?
I will give you an example. For you to get a cycle for trastuzumab, you need about 12 millions. Now, 12 millions
per year?
Only one cycle. But you may need about 10 cycles. So that means a person needs about 120 millions for one breast cancer patient to get through. That is minus the conventional treatment, because it has to go along. So that means if you include the conventional treatment plus all the others, the person will need about 200 to 300 millions for only one breast cancer patient to be treated through in that case. So what we are doing as Cancer Institute is to lobby that we can lower these prices, that a person probably needs only about 20 millions to get this treatment. And that's why we have said that we have now done the access. Most of the drugs we are lowering the prices because we are negotiating and trying to talk of the economy of scale.
So when you have them here at the Cancer Institute, do patients pay or you pay for them?
Cancer Institute is a government or a public facility. All medication that we do have, as you see here, is free of charge.
Even if it's 12 million?
Even if it is 12, even if it is 100 million, it is free of charge. All medications are free of charge.
This is Mr. Godfrey Osinde, who is the head of pharmacy, and explained to us what is going on at the Cancer Institute Pharmacy. Looks like they can access even the most of the expensive medicines, including the monoclonals as he has described them. As you have seen, chemotherapy is safe. We have had stories from the people who have had it. We've heard from those who actually are responsible for giving chemotherapy and making sure that it is kept safe. The message to you is, if you've been prescribed to have chemotherapy as part of your treatment, fear not, because it is for you to get better. We've seen people getting better, and we encourage you to adhere to treatment. Once you get side effects, to make sure you report so that the doctors can help. Once again, I thank you for watching U-Health Chat, and this program is proudly sponsored by the National Medical Stores.
Was brought to you by
U-Health Chat is brought to you by National Medical Stores, who are mandated to procure, store, distribute essential medicines and medical supplies to all public health facilities in the country.